Welcome to Chronic Choices, Critical Voices, a discussion series that brings together diverse perspectives on health policy and the lived experience of millions of Americans managing one or more chronic conditions. I'm Ken Thorpe, Professor of Health Policy at Emory University and Chair of the Partnership to Fight Chronic Disease. In this discussion series, we're talking with important stakeholders across the healthcare continuum who know that innovation, coverage, and access are all critical components of improving overall health outcomes for people living with chronic conditions. Today, I'm happy to welcome Gary Puckrein. Gary is the President and Chief Executive Officer of the National Minority Quality Forum, a not-for-profit organization that he founded in 1998. The forum addresses the critical need for strengthening national and local efforts to use evidence-based, data-driven initiatives to guide programs to eliminate the disproportionate burden of premature death and preventable illness for racial and ethnic minorities and other special populations. The goal of the forum is to strengthen the capacity of local communities to eliminate the disproportionate burden of premature death and preventable illness in minority populations through prevention, early detection, and control of disease complications. Dr. Puckrein also serves as the Executive Director of the Alliance of Minority Associations, a collaborative effort of the Asian and Pacific Physician Association, the Association of American Indian Physicians, the Inter-American College of Physicians and Surgeons, and the National Medical Association. It was formed to address the significant disparities in healthcare treatment plans and outcomes among many underserved populations within the United States. Gary, thank you for joining me today. Let's dig right in. Recent Quality Forum analysis, Most Favored Nations versus Mother Nature, How Federal Price Controls Fight Biology and Patients Lose, argue that biology doesn't wait for bureaucracy. Can you explain what that means in practical terms for a Medicaid patient with cancer, Alzheimer's disease, sickle cell disease, or another progressive illness? How could MFN pricing model unintentionally delay access during the window when treatment has the greatest chance of preserving health?
So where we always need to begin the conversation when we're talking about healthcare is our biology. Our biology has its own rules. We actually can't control those rules. And the role of medicine really is to mitigate patient risk, keep us out of the hospital, keep us out of the emergency room, keep us from disability, keeping us from dying, and helping us to live high quality, long lives. And so when you use that metric and you look at something like MFN, you have to ask yourself, how is that contributing? And if it's not contributing, is it elevating risk? And our point is that when looked against our biology, MFN elevates risk. It elevates risk in the moment, meaning if you look at the countries where we are taking those pricing models and importing them into our system, they ration care. They limit access. I mean, that's how they do it. That's how they essentially do it. They use quality metrics that impact disabled populations. And so in the immediate term, what we're going to see is the rationing of care and limited access. But even as important is the future in terms of the ability to continue to innovate. America is the largest innovator of healthcare in the world. The science of innovation is really built here and then spread throughout the world. And do we want to lose that? And even more importantly, for all of the diseases that you just mentioned, we're actually in a medical revolution where we are reforming the way and approaching the way that we're delivering care that prior generations could not even imagine. And so I think that's the challenge of MFN. It's really going to disrupt all of that.
Yeah, those are all good points. And certainly if the focus is on reducing the growth and level of Medicare and Medicaid spending, there are clearly more effective models that we have. in place today that really focus on prevention and more effective care coordination that would generate larger savings without having all the really unfortunate impacts, Gary, that you talk about. It really does have an impact on access and innovation, no question. So, supporters of MFN focus on lowering government spending on that point, but Medicaid serves children, people with disabilities, individuals with rare diseases, and many patients from historically underserved communities. What unintended consequences concern you the most if manufacturers decide to delay launches, limit availability, or reduce investment in therapies that primarily serve Medicaid populations?
So let's be precise. So right now, if you go to attend any of the cancer meetings where the innovators in cancer are participating, be it diagnostic companies who are saying that they are developing algorithms, blood tests, and other things that will look at cancer well before the individual is symptomatic, that maybe 5, 6, 7 years before the disease manifests itself in stage 1, we can pick up the signal that cancer is now developing in the body. You have innovative pharmaceutical companies who are saying that we are developing medicines that will treat that what we call pre-symptomatic disease before you're symptomatic. So before the cancer reaches stage 1, we now have both the diagnostics and the treatments coming in stream. There was a recent paper published at the University of Chicago that was saying that by mid-2030, we will have brought the war on cancer to really an end, meaning that in the same thing that we did with HIV, turn it into a manageable disease, or hepatitis C, we're about to do with cancer. The savings are so large in the trillions of dollars of savings, right? And so to get from here to there is not MFN. It is not kicking people off of Medicaid. It is not denying premium support. It is the investment in the science and technology and making sure that science and technology reaches the broad scope of the American public. That's where we are. That's the moment.
Yep, those are all good points. And I think, the couple of points that you raised, one is that the science is there, and it's an exciting time right now in terms of cancer and Alzheimer's research and in other conditions that we haven't had treatments and cures for previously. But public policy, as we're discussing it, is discouraging it through things like MFN. So we have the scientific innovation going on, but we don't have public policy moving in the same direction to support it. So that's really really unfortunate because it's an exciting time in discovery, and we do have an opportunity to develop the types of cures you're just talking about that would serve millions. And I think the other point raised is that the Congress, I think, is just focused on silos of spending, and they don't understand, I don't think, the interactions between innovations in medications and drugs and the impact it has on reducing things like hospital spending, emergency room visits, ambulance rides, strokes. And so we've got into this siloism focus by just focusing on drug prices without understanding that the real focus should be on the total cost of treatment. And there are interactions between innovations that are going to be discouraged through MFN and savings that we're not going to get as a result of that through reductions in hospital admissions, length of stay, and ER visits. So, that's a perspective that we need to just continue to point out. The forum argues that innovation itself is a health equity issue. How do you respond to those who view lower prices and innovation as competing priorities? Why do you believe that preserving incentives for new medicines is particularly important for communities that have historically faced the greatest disease burden?
So I'm going to broaden our language on health equity by way of an example. So right now, there are um, early detection diagnostic, and I'm going to stay in the world of cancer, but obviously, as you said, that Alzheimer's, Parkinson's, I mean, there's a whole new world opening up there. Uh, in the world of pancreatic cancer, so if you get diagnosed with pancreatic cancer today, um, life expectancy, if you're really lucky, 5, 6, 7 months, because we don't have screenings or haven't had screenings for pancreatic cancer. We're now seeing early diagnostic for pancreatic cancer before the individual is symptomatic coming on screen. Just been announced that there are signs that we have a treatment, early stage, not perfect, but early stage for pancreatic cancer. The inability to provide that diagnostic and that treatment to the public, I would call a health equity problem. I would say that we have failed the American public because we have the capacity to provide them with a level of care that, as you rightly say, that our members of Congress haven't paid attention to. That they're off over here talking about, I would describe it as 20th century medicine, when 21st century medicine is opening up and creating tremendous opportunities. And so people think when we use the word health equity, we're simply just talking about the underserved population. But we would say that underserved population is anyone who doesn't have access to what science gives us the capability to deliver.
Oh, I think that's a really excellent point. And, again, on this broader theme that, the unfortunate consequence of this MFN focus really is on discouraging innovation in an era of really exciting scientific discovery and opportunities that are going to perhaps be delayed or just not happen as a result of, as I just talked about, this silo-based focus simply on drug prices and without focusing really on a broader view of how do you reduce the level and growth in Medicare and Medicaid spending through prevention and through more effective engagement and working with patients to coordinate their care. Certainly that benefits patients. It will save Medicare and Medicaid dollars, but it won't have these dysfunctional impacts on innovation and access to new medicines. So I think that's an important point to keep raising to members of Congress that we need to get back to this broader focus on the total cost of care and not sort of simply a silo of pricing in the healthcare system. You've raised concern about importing foreign pricing systems that rely on quality adjusted life year, quality methodologies. Why do you believe these frameworks risk undervaluing treatment for people with disabilities, rare diseases, communities of color? And what should policymakers use instead when evaluating the value of new therapies?
One of the unique things about America is really our social contract, which gets articulated as life, liberty, and the pursuit of happiness. When Jefferson was writing those lines, the actual words he was using was preservation of life in our social contract. And that preservation of life didn't discriminate in terms of people with disability or age or gender or race. It was the responsibility of government as part of that social contract was to provide for the preservation of life. Now, Jefferson didn't know and anticipate where the science was going to take us and lead us. But when you start to import really what I would call foreign metrics and foreign ideas and modalities into our healthcare system, um, it will have a profoundly negative impact because those systems don't look at the biology and don't understand that the biology has rules, and no MFN, no public policy, no declaration, no congressional act is going to change what the biology is going to do. And my sense is we have a responsibility to each other in our social contract to make sure that we're providing quality care, I would say optimal care to everyone who comes into the system.
Well, that's that's a good point, for sure. And the irony is that by uh, linking U.S. drug prices to a market basket of largely European countries, all of whom use QALYs to set drug prices in different ways, one way or another. But those QALYs in those different countries are based on the preferences of patients in Germany or Denmark or the United Kingdom, France, and so on. And the goal was not to import QALYs in setting these MFN prices, but that's exactly what we're doing. Uh, by linking it to that market basket of European countries, all of whom use QALYs, all of whom have patients in those countries with different preferences compared to the United States, we're really importing European preferences for trade-offs between different states of health into how we set drugs and drug prices. So again, just another sort of, I think, dysfunctional aspect of this MFN proposal that we're discouraging innovation that we don't need to do. We can reduce the level of growth and spending more effectively to improve patient outcomes. But we're also importing patient preferences from overseas. So it has a whole series of dysfunctional aspects to it that I think are really uh, sort of unfortunate consequences that we don't have to take on. Everybody agrees that patients need affordable medicines, but they also need timely access to future breakthroughs. If the Congress and administration want to lower costs without creating the unintended consequences you've described, what policy reforms would better balance affordability, innovation, and equitable access for Medicaid beneficiaries?
One of the reasons why I admire the work that you do and your organization does is that it brings the patient voice into the conversation. I would dare say, and I haven't seen anyone go do it who are proposing MFN, is to go to those countries where access is being limited and ask the public, would you like to have that system? Or would you like to have a system where you have access to innovative therapies that can do all of that risk mitigation for you, keep you out of the hospital and emergency rooms and disabilities and actual death, right? And that's the point, is that they don't want that either. And we're taking what they don't want and we want to import it into our system and really deliver it up to the American public. I don't understand the point, and it misunderstands our future. It misunderstands where we're going and why we need to get there. And I think organizations like yours that bring forward that patient voice and signal that members of Congress, CMS, and other policymakers need to hear. They need to listen to what is essentially consumer demand. And consumer demand isn't asking for MFN, isn't asking for using foreign models and bringing them into our system. I think that's really the question at hand. What does the American public actually want?
Well, I think to that point, if you look at the polling, they are focused on the affording healthcare and the cost of healthcare overall. And indeed, one of the most important components of the Inflation Reduction Act to me was the cap on for Medicare patients annual out-of-pocket expenditures. It's $2,100 this year. Monthly cap on insulin at $35. We've already taken care largely of the affordability issue for drugs for patients. So that's in the Inflation Reduction Act. And so again, this broader discussion about the budget and Medicare and Medicaid savings, I think we need to take a step back and really look at how can we reduce the level and growth in spending, but benefit patients, improve patient outcomes, and not have these dysfunctional side effects, Gary, that we've been talking about on innovation, on importing European patient preferences into our system, on perhaps limiting future access to scientific discoveries that are just really unnecessary um, aspects of what they're trying to do in Congress in terms of saving Medicare and Medicaid budget dollars. We have more effective and efficient and bigger opportunities here. We have models that we've seen that work in Maryland and Vermont that the CMS has evaluated that show that those approaches that focus on prevention and care coordination can reduce net spending by about 10%. I mean, those savings dwarf what they're getting out of the most favored nations savings, and it has not only none of the dysfunctional aspects that we've been talking about here today, but actually improves patient outcomes and improves patient health and prevents the growth in chronic disease. So I think we need to have a policy reset here and really look at opportunities more broadly to make healthcare more affordable, which is what patients are asking for, is they want to be able to afford their healthcare. But we're really not providing the answers that we really do have right in front of us. And certainly the MFN approach is not the direction that we should be going. So, Gary, I appreciate the time today. I don't know if you had any closing thoughts.
Well, just a big thank you. I appreciate the opportunity. MFN is an idea. Hopefully, we'll get over it quickly and put it on the shelf and really focus on the things that are really important here. As I said, we're in the middle of a medical revolution. It needs investment. We need to be able to bring levels of care throughout the country, and I think that's the work at hand.
I agree. Yep. This is an unforced error here that we don't have to suffer, really. We have better solutions that actually save money and improve the health of patients and encourage discovery and innovation for the future. We need to think about that more broadly than this really more narrow silo-based pricing approach that the Congress has gone down the path of. So, Gary, I appreciate the time and as always, enjoy the conversation with you. And we look forward to our next discussion.
Great. Well, thank you so much.
Thank you.